Okay, so we have issues pushing a patient into return to sports. Okay, and what do I normally see return to sports issue? You will find that it's very, very common sense, right? The first one is swelling. When I see a patient that still have swelling, and usually due to excessive loading and so forth, you can push for strength, but your strength load is around 15 to 20 reps one, right? So you can still push for range of motion, which is aiming for full. Okay, you can still push for strength, which you aim for 15 to 20 reps. But are you going to push for plyo or change of direction as part of the plyometrics type family? No, right? When there is a swelling in place. Now, here's a scenario change whereby swelling has reduced. Now we have range of motion, and the range of motion in region is very fussy. I need to make sure the ankle is moving well, the hip is moving in its full range of motion. Yeah, active, active with control, right? And or passively the kneecap still got a little bit limitation of range of motion. Problem. So this is partial range of motion. So it's no brainer that range of motion practice has to be full. Full means super full to the level that I need it, like hip ER, hip IR, like patella, knee extension strength and all that has to be full. Strength wise, can you start loading a little bit more? Yes, you then start to load the 8 to 12 rep range, but you won't be able to go full range. You encourage the range, okay? But plyometrics is still no at this stage, because if you load it and you don't know where you're at with it. Now the question is that I got asked today is, how do I translate to this part where people are all talking about? Okay, there are certain ways to achieve this in region. Okay, so now we're assuming range of motion is full. Okay, and they should achieve it within 4-6 weeks of procedure. And if it don't, there's a problem, right? Like maybe they have degenerative joints or there's a problem with the physios. When the range of motion is full, then your question will now be not looking at the range of motion already. Your strength, you'll be looking at strength. How do we quantify the strength? Okay, yes, us having certain assessment tool, the range of motion is the strength is something that we measure through some functional movements. So for example, we're gonna have a single leg squat for control and strength. Okay, they need to minimum achieve the same amount of repetitions with control, with obviously at this point no more pain reproduction, as many reps, right and left. That will take control into ankle stability, knee stability, and hip stability. You're measuring reps, means that you're measuring the endurance strength, right? Not explosive strength. Or you can look at the ability of a person to do a leg press. Okay? Now, this one you can look at maximum weight kilos, okay, for a set rep. So we say, I want you to do something that you can do a maximum of 5. So we're doing a 5R rep max. Okay, we control, and that 5 rep max, right equals left. But bear in mind, when you do leg press, your control of the hip, of the ankle, and of the lumbar pelvic is lesser of a focus. You're measuring more or less a very stable position environment, and you're measuring strength only. Okay, and the most scientific way of measuring it obviously is your isokinetics. So in isokinetics, I don't have money. Alright, I don't have money to buy an isokinetic toy. Therefore, what we have shifted it towards, and that's the direction of the whole world physiotherapy is moving towards, and you guys need to know, right? Which is manual muscle tester. Manual muscle tester And how do we measure it? And what are we actually measuring? We can measure a maximum strength that they can hold for 5 seconds for the endurance strength. But that is not a close representative to what the research is measuring. The research is measuring how fast a force can be generated at a how strong that strength can be generated as well. So there's speed and force component of it. So if you combine those two minus a bit of the time component, they are roughly equate to your maximal peak load. Okay, so the instruction will be you do a manual muscle tester. Okay, we have 2 manual muscle tester, which I don't think you guys know. One is Tyndall, which is very nice with an app. There's a chart to show how much the patient can push, and also second is the Commander manual muscle tester. Okay, Commando manual muscle tester is very good for what we call the hip area muscle groups. Okay, I will try to charge it and I'll try to show you guys. Okay, then you have your Tyndall, which is you can do a left-right comparison for peak load. Very easy. You go on to download the app and you see it. So we are gonna do a tutorial on how to use manual muscle tester for the hip, for the knee, and you guys have to attend, especially if you want to then know how to progress to Plyo. Okay, let's just say now at this present stage, our manual muscle tester load right equals left roughly about 70-80%. Number one is we know the accuracy of this is variable. Okay, it depends on the motivational value of the patient. It depends on how strong you're encouraging them, how competitive they are, and so forth. Okay, day to day they will also change quite a lot, but you're measuring day to day on the same person, opposite leg. So therefore we're minimizing the variability here. Okay, and remember there shouldn't be pain reproduction. Pain will induce a lower outcome as well. So say your output is about 70% strength as compared to the injured side or non-injured side. Can you start Plyo? For sure, but your Plyo strength that you accept you're doing, the drills that you're doing, will be more towards the bounding, the frog, the kangaroos. You're gonna do more the kangaroo Plyos, learning the bounce, learning the slow jog, the runs. And we're not doing hill sprints, we're not doing 30-second sprints, we're not doing vertical high jumps and all that. But we are doing bounding up the step, bounding on the spot, bounding pogo style, bounding single leg, bounding change of directions. You name it, you should be starting it when the range of motion is somewhat full and there's no more swelling. Okay, because we know with plyometrics we get the most proprioception input to the brain, and in turn they were going to build the strength. So these are all the functional strength that you guys are missing out on if you don't get your patient to do plyometrics. Elderlies also can do plyometrics, just that they are doing it more at a bounding, okay, or they're doing it at a maximum isometric against something but fast peak, right? So for example, they just have a squat rack block onto the hooks and they cannot move on and they push as hard as you can and then let go. That is plyometrics to them. You're force generating as fast a force as you can, but yet you're not introducing movement. There's no movement, but the speed of contraction is super high. And that's where I think, we're lacking. And I do sincerely hope this would be part of our knee OA program, but this will be part 2 of knee OA program. I don't want you to be killing our patients. First 8 weeks, just start to find some strength and functional movements only. But part 2 will be make them a better person. Okay, and stop.